welcome back. It's great to see so many of you dropping onto the gamification leaderboard. Workforce management is our third panel of the day. Management within NHS trusts is vital to improving efficiency, quality, and patient satisfaction. Time and scheduling are essential for any workforce, and yet senior members can often lack the resources, training, and equipment to carry out these tasks effectively, in turn taking away from time that could be used to focus more on patient care. In this leaders' debate, we'll discuss innovations and processes that other senior management teams can apply within their workforce to help them carry out their roles for the benefit of the team and their patients. So I'd like to introduce you to Professor Makani Purva, Chief Medical Officer at Hull and East Yorkshire Hospitals NHS Trust, and Juliette Cosgrove, Chief Nurse and Director of Clinical Governance from NHS Professionals. This is an intimate panel with just Juliette and Makani, so do join in using the live Q&A function. It really is rewarding actually for me to understand the parts of the conversation that you want to know more about, and your thoughts, of course, are really important. So a very warm welcome to you, Juliette, joining us from Berlin, very exotic location to be joining us from on this conference today. And Purva, who's just made herself a cup of tea and had no breakfast. So I'm glad that I've got both of you here. Purva, we have got a bit more luxury on this panel. We don't often get the time to hear about people's backgrounds and what they do. So I think we'll start off on a gentle note. I know you're a consultant anaesthetist and founder of Hull Institute of Learning and Simulation. So tell us a little bit about you to begin with, if you would.
Yeah, thank you very much. And it's great being part of this panel. And I think it's especially relevant post-COVID to be addressing one of the biggest challenges we have in the NHS today, which is workforce. So my background, I'm an anaesthetist by background, have been an anaesthetist for nearly 30 years, which I suppose gives away my age slightly. I've been in Hull for 20 years, came as a trainee and stayed here. And it speaks volumes about workforce recruitment and retention, isn't it? Because I live 50 miles away, so I actually do a 100-mile commute every day. But the reason why I'm in Hull is because obstetric anesthesia is a specialty, a subspecialty, which is well recognized internationally in Hull. So I stayed on as a consultant, and then I went into medical education initially. So I have my interest in simulation, and my honorary professorship is in simulation with the Hull York Medical School. So I was a director of medical education for a few years. And then quite strangely, I went into a role which was called the anti-bullying czar role. About 8 years ago, we had an issue in Hull, which I'm glad to say we're in a far better place now, where we had some issues around bullying and harassment. So I was appointed as anti-bullying czar. And over a period of 2 years, along with HR and colleagues, we effected a cultural transformation. Soon after that, I went into a management role, deputy CMO, and now CMO for about 3.5 years. So that's where I am. Yeah.
Wow, that's incredible. And Juliette, tell us a bit about your story, your backstory to becoming Chief Nurse and Director of Clinical Governance.
Thanks, Helen. Thanks and good morning. Interestingly, my clinical background is in intensive care, an intensive care nurse. So probably, I don't think I've crossed your path, Purva, but certainly understand the pressures that you have in the areas you work. But yes, so I was a clinical nurse for quite some time, actually. Loved doing that. Worked at advanced practice level, and then got a real interest in patient safety. So I was working at these teaching hospitals on big patient safety improvement programs, particularly around infection prevention and control, obviously quite relevant at the moment, but also in other areas of patient safety. Also, through that, I got a kind of real interest in governance. So I spent a lot of time working with a couple of different organisations on improving quality of services through improving governance. And then I had my first chief nurse role at Southport and Ormskirk NHS Trust, which was kind of a turnaround job, really poor standards of care, through poor workforce, not enough people, not enough skills, and kind of not enough focus on what it is we were there to try and do. So really enjoyed working there, actually. We got some significant improvements, great team. And then NHS professionals role came up, and we had quite a few conversations about whether, you know, my skills would be suitable for this organisation. And I just thought it was really interesting to go work in a workforce organisation and see if there's a different way of doing things. And I've completely changed my mind in the last 2 years about if I was to go back now into a chief nurse role, I would do the workforce management entirely differently. So,
Gosh, well, tell us, Juliette, how would you do it differently?
yeah. So I think we, if we just think about how we think about vacancies and how we think about flexible workforce. So at any given time, most organisations, certainly in acute sectors, will have vacancies of around about 15%, and that will be filled by a temporary workforce, mostly bank and some agency. And most of the organisations that I've spoke to pay no attention to that workforce whatsoever. It's a significant area of their workforce, and it's an area where there's quite a lot of skill in there, but they're not seen as part of the team. And the things that I learned about patient safety were, if everybody in the area at the time don't work as a team and don't have an opportunity to the same training and don't work together and learn together, then that'll impact on patient safety. So patient safety features would be important in making sure that the bank members, the agency staff and the substantive staff all know how to do the same thing. So that's kind of one area. And then the other area is around the kind of management of that. So we'll spend a lot of time managing the substantive workforce. We'll put rosters in, the way we recruit them, where they work, what their skills are. And then there's another portion where we just allow the workforce themselves to deploy themselves. And so therefore there's no control of that 10 or 15% of the workforce. So two things really, like, training, access to being part of the team, but also actively manage that workforce. And we've got some great technology to do that. And I think we've not really changed. I don't know, Purva, from your perspective, but the way that we roster nurses now is exactly the same as it was when I started nursing in 1985. We use a system to do it, but it's essentially the same thing. So, and people don't want to work like that anymore. So yeah, long answer to that one, Helen.
No, a long answer, and I'm sure Purva's got some comments on that before we move on with the next question. Purva, do you find the same things? Do you agree with the points Juliette was making there?
Absolutely. So the e-roster is something that is a heavily debated topic in every organization, because it has been a success to a certain extent with nursing rotas. And there is a suggestion that we should do similarly with the medics. And I'm afraid about that, of doing exactly that, because I'm so glad that Juliette, you brought up the issue of rostering, but because there's a perception that the way it was done with the nursing colleagues should be replicated. And I'm glad to hear that we have lots to learn from that experience, and we have to refine it and modify it before we then decide to take it across to another part of the workforce. So I think the problem we have with specifically with rostering is that we don't make it individualized, personalized to the specialty. One size doesn't fit all. And if you do that, you lose your workforce, because every person is special in, just like we treat every patient differently, we've got to treat every workforce member differently. Just giving them a rota pattern and treating them as a number on that rota pattern will be the last thing you should do. And unfortunately, that is the way I think most managers want to approach rostering as, because that's the easiest way of sorting out a workforce problem. Put it into a roster, see where the gaps are, move people around, and that's it. But that's the way you lose people as well. So I completely agree with Juliette.
So rostering, Purva, is clearly an issue. What are the other big challenges for the medical workforce going forward, do you think, that you've identified?
So I think the big challenge which COVID has exposed is the lack of slack and the lack of resilience in the system. What we were doing pre-COVID was just about managing with the minimum workforce we had. So if you look at our junior doctors, there's always the issue of service and training. We were able to get away with a lot of service out of our trainees. And we try to squeeze, because of financial pressures, try to get as much as we could from the medics, so that even if we had 1 or 2 people short, we could try and just manage it to the rest of the workforce. COVID came along, it wiped all that out, because as you know, the sickness levels, absence levels has gone up, and it exposed all the holes in our strategy. So the biggest challenge, I think, is firstly an acknowledgement that we have a huge problem, which I think not many of us have done it. And the second is a real thorough look at what are the numbers we require. I think we're afraid to do that because we don't want to hear the answer. We will require far more numbers and types of healthcare professionals than what we are looking at the present moment in time. And apart from numbers, it's also to look at how we can adapt the workforce to new ways of working. As you know, face-to-face and virtual, the two are blurred now. There is more of care delivered closer to home. Acute sector has ever worked like that. It has always worked within the confines of a hospital. How do you make people work differently? So the challenges are numbers, adaptability, and then trying to fit these new models of working around that new workforce. So huge challenges.
I think, Purva, it's really nice to hear you speaking so frankly, because we love our NHS. We're very proud in the UK of our NHS, and we hate to criticise, but having had a bit of a personal experience with my mum and dad over the coming weeks, I've seen some of the holes. And would you agree, Juliette, that the pandemic's perhaps exposed some of those gaps and some of the weaknesses? And do you agree with Purva that we just have to be honest and accept that changes are needed and we have to face up to what seems to be a crisis now?
Yeah, I mean, I completely agree, Helen, with Purva's point. And it's quite interesting, just a few interesting statistics here. But say, for example, one of our big organisations where we supply the bank, so the staff just doing bank, we're contributing about 500,000 hours of care, which equated, if you're looking at whole-time equivalent, it's just short of 300 whole-time equivalents, but 1,500 people were doing that. So actually, it's the numbers, but it's more than you think. So when we typically would think, so we need like 20 whole-time equivalents, but that might be 30 people, might be 40 people. And if we don't make those adaptable patterns of workforce like that Purva had said, then those people won't stay, and then we'll have an ever-increasing crisis, because a lot of people, I mean, certainly nursing, it's heavily dominated by women, and I'm not saying just women have care and responsibilities, but we typically see that women do. I know that men do as well. So, in order to kind of retain all of that skill, we're going to have to think that it's more than the whole-time equivalents. It's a significant more number of people. And I think as Purva's point is, you have to start treating people as individuals if you want to see them have a 40-year-long career in the NHS. I mean, I was speaking to a newly qualified nurse last night she's been called about 18 months, and she said, I don't want to work these shift patterns the rest of my life. I can't see me doing that. I love the work, but I'm not going to work like that. I've got a life to lead. So it's, there's a lot more attention needs to be paid to the numbers and the people. Yeah.
Absolutely. But I think that, that's why it's important. I think that we've got, leading lights like you two have both been within the NHS for so many years, and I think your thoughts are very valuable and need listening to. I mean, one of the things, Purva, that we've missed out over the last 2 years is probably a loss of training, and I just wonder how we accelerate training and learning in a post-COVID world as we try to get back to some kind of normality, and how can we compensate for that lack of training?
Yeah. It's interesting you should say that, because the last night I was chairing an event. It's called the GNSH, which is the Global Network of Simulation in Healthcare, where we had WHO presenting to us on what their training objectives were for the healthcare workforce. One of the things that they came up with was, because I posed that question to them about challenges of workforce in the modern world. How are we going to do training? Because post-COVID, as you can imagine, all the organizations have got backlogs. All they would like to do is to get their workforce to do service and as minimum as possible of training and education, because we have so much of backlog. We want 105%, 140% activity. So the interesting thing is, I think the traditional models of teaching and training we did pre-COVID. So you give them, so if it is for doctors, you have your dedicated teaching session, dedicated training session. You have what we call as SDT time, which is supported development time. All that is going to be quite squeezed out in the modern world. So what we have to look at is mobile learning, for instance. So learning at the time of resources that are provided in real time at the point of contact with the patient, for instance. So one of the things that the WHO is recommending is that we should use even better the smartphones. Everybody has a smartphone. How well are we investing our energies into adapting the various apps that are already present, which can actually provide real-time information about patients, so real patients, so that you can actually deliver it. So that's just one small example. The other example, and of course, a bit of a plug for simulation. If I didn't talk about simulation, that would be strange.
You're internationally renowned for simulation. It would be very odd if you didn't mention it.
I didn't say that. So one of the things that we have perfected, well, I wouldn't say we perfected, we're trying to perfect, is what we call as low-dose, high-frequency simulation. So we're providing, so for instance, for nurses, because we had a lot of instances of near misses around management of hypoglycemia and hyperglycemia. So we gave 15-minute short bursts of simulations for the nurses on the wards in real time, so that when they return back to the medical ward they were working on, they could apply that learning straight away. So we have to look at different ways, because that the traditional model of a day out of training, going and sitting in a classroom, we might still have to do it, but I think we are still quite behind in delivering mobile real-time institute training. That would be my challenge to the healthcare going forward.
I'm sure Juliette will pick up on that, but you were Chief Nurse and Deputy CEO at Nightingale Hospital Northwest, Juliette, which I was fascinated to learn about. I mean, what learnings can we take away from the pandemic in terms of innovation and thinking differently, and the approaches to flexible working, and the things that Purva was talking about there in that last answer?
Yeah, thanks, Ellen. Yeah, I mean, the Nightingale was a fascinating experience, actually. And one of the things that, picking up on Purva, is we brought people into a very unique environment. It was, so even things as simple as how would you respond in a fire? Very, very different, because there wasn't a fire system in there. So, and how did we then think about how you might do resuscitation, and how might you evacuate, all those sorts of things. So we really went down that kind of drills-based approach. Let's practice it. And it was really important to me at that point that however we brought people in, that we did pay attention to their induction, what it is that we want them to do, both kind of from an environmental point of view, where do you find things, really important, but also how do you communicate with your team, and how do so it was really interesting, because people became very, well, I would say they became very vigilant in those situations. It felt safer because of their vigilance. And we brought people in, obviously, sometimes some people had never worked in healthcare before, and certainly no one had ever worked in a converted train station. So those things that Purva's talking about is, it all comes back to patient safety, doesn't it? So if you don't give people the skills and knowledge to be able to work within a team safely, then the outcomes won't be safe for the patients. And when Purva was talking, I was thinking about some of the best training that I've ever had is that where I'm doing the thing that I'm supposed to do. So I learn by doing it. I don't, and I don't learn by reading it or, having someone tell me. I've got to then go apply it in practice. And I was just going to make one point really about the difference between the workforce that is the professional workforce. So those people who come through professional qualification with a certain academic level of background, have been taught in the schooling system for quite some time. By the time you finish anything for a professional, you're at least 20, you're coming out of full-time education about, at least 20, 22 years old. We've got a big workforce for whom, that they don't have that opportunity. So we've got to really think about how the kind of the non-professional workforce is trained and developed as well. And we don't pay enough attention to them. And I think, there's a real opportunity to look at how you might use simulation, how you might look about learning in practice with that workforce as well. As you said, that purpose, thinking it would be great if we did more of that. You know, I think some of that's really simple things like where, you know, how do you put things away? Where do you find things? So, you know, it's some of the simple things that add to safety. Yeah.
Yeah, I could imagine the Nightingale was a real learning curve, and that you can take some learnings away. Pam just wanted to add to the conversation, saying we need to really think out of the box and trial different ways of self-rostering of the workforce. And I think that's something that we've sort of talked about quite extensively. But Purva, how can we improve retention in the harder to recruit specialties? And indeed, what are the harder to recruit specialties?
Yeah. I mean, I think that is a constant struggle. And right now I'm working with one of the specialities, which interestingly has a problem across the country. So in the UK, we struggle traditionally with getting doctors in certain specialties, and I think now increasingly it's becoming clear that for our nursing colleagues as well, we need to do overseas seems to be a route that we are dependent on. Now, actually, interestingly, I've also I have a lot of connections, as you can imagine, with India, and we have an MOU. Our organization has an MOU with the university in India, which we use for recruitment. But one of the problems I think we have is that the UK is becoming less attractive for overseas recruitment. We have to accept that we will never have enough workforce from within the country, and therefore overseas will be almost a permanent means of supplementing our numbers. And also there's enough evidence to suggest that diversity in our workforce actually enriches our experience, and it actually brings a lot of advantages. You know, compassion and care actually improves when we have people from different backgrounds. And interestingly, if anybody is interested, that map behind me is not just so that I can look at the world map and decide where I'm going to next on my holiday. It has little red dots on it. Those are the signifies the country of origin of the consultants in my organization. So you can see a lot in the UK, obviously, but the rest of the world as well. Just to demonstrate that the more diversity we have, we actually bring more qualities. We bring people from different backgrounds. So going to the question of how do we do it? I think when we bring, it starts right from the GMC. So the processes that the GMC, and the same applies for the NMC as well, making it easier for people to apply, making it easier for people to get the registration, the equivalence, making it easier when they come in and settle down. Culturally, it is very different. How do we support them in the initial year? How do we make it easier for the spouses and children to settle? So because we usually discuss it in terms of the individual, the doctor or the nurse, or whoever the healthcare practitioner is, we don't look at it holistically. And I think that is a mind shift that we have to do. I mean, we have a fantastic HR director who actually recently helped us find a job placement for the husband of a consultant in a very difficult sought after specialty. I mean, it was absolutely fantastic what he did. And I wish more HR directors would do that. But that's the sort of thing we have to do. Think out of the box, look at ways of recruiting, look at them as a whole, as a family, and then support them.
Purva, just briefly, is the UK not as attractive anymore for overseas consultants or nursing staff?
So I don't know about the nursing staff, but I can say of the medics. So so previously we used to have very clear training programs for overseas doctors when they came into the NHS. Having said that, the NHS is still very attractive. There's nothing like the NHS anywhere else in the world. But there used to be specialities and programs where training was earmarked. And at the end of the training, you could apply for your CCT or your CSER and become a consultant. Or if you return back to India or wherever, they would have enough of experience. Because of the denuding of our workforce and because of the reduction in the workforce, there is a greater and greater expectation that people who come into training posts also end up doing service. So what you then end up doing is seeing every person. It goes back to this, I think, this theme on not looking at the individual person's requirements, treating them as another number on the rota. So if you have a new person who comes in, we look at them with glee and think, right, let's put them into that theatre list, which runs from 8 a.m. in the morning to 8 p.m. That theatre is now sorted, rather than thinking, okay, when he's doing that, who's going to supervise him? What training does he get? Does he want to do that particular list, that particular specialty? So what we're doing is that when people come from abroad, we don't actually provide them the same training exposure we had before. So for instance, for our own consultants, our consultants want to do training lists, which means that you can do fewer cases in a particular operating theatre list. But because of the pressure to get throughput, we have reduced the number of training lists we provide. So why would somebody come from abroad and then find he's doing the same, bread and butter cases, but not doing those unique cases? So service, consultants not being given time to do the training, and the recognition from overseas graduates that they can go elsewhere now for getting the same experience. All of those three makes UK not such a great training experience, unfortunately.
Juliette, lots of points there that Purva made about overseas recruitment. Do you want to add to that? Although she did that very eloquently, but anything to add before we move on?
Yeah, I think probably the only thing the comment I would make is for nurses, we're still a very attractive place for overseas nurses to come to. So we're having probably one of the biggest overseas recruitment campaigns we've had in my kind of lifetime practicing. And I think we are paying a significant attention to the cultural needs, not just kind of a cultural in terms of professional cultural differences, but also the personal cultural differences that you kind of need to make people feel that they're part of a community. And I think someone's asking a question about the nurses overseas who can't pass the English language test, and is there something different? And I think the more time we spend working in certain countries about where there are nurses who want to come over, then I think it's working with those countries to how might they improve English language. But I still think there's if we find in specifically very hard to reach. I mean, one of the areas we're looking at the moment is in midwifery and mental health nursing. So they're harder to recruit to from overseas. So I think if we did find that there was pockets of people who couldn't speak English well enough to pass the test, then we could do some specific work in those harder to recruit to areas. But for nursing at the moment, it's still a very attractive place, and we seem to be doing it really well.
That's good to hear. Juliette, Ray says, digital technologies can shift the old top-down performance management to the new world's bottom-up performance empowerment, enabling all staff groups to drive their rotas, learning, appraisals, and all continuous performance themes. The question is the NHS reverting to old solutions to fix new problems by not engaging with these technologies quicker? Thank you for that, Ray.
Yeah, I mean, and I would wholeheartedly agree with that. And I think that's part of the points Purva was making around not giving people enough time. So there's a lot of focus on getting stuff done rather than thinking about the best way to do them. So it's the opportunity to stand back and look at the problem differently and think, what technologies are available? What do we know that the workforce wants, and how might we give the workforce what they need using technologies in order to be able to better manage it? So I was at a conference with some chief execs last week actually, and I said, what about giving the rota to your bank staff first? Because you'll get maximum use out of that. Why not because I don't Purva will know that most people who work in the health service will always want everything to be right. So if you empower people as much as you possibly can, and management of their own shifts is one of the most. It's very, very important to people. What's there to lose because we're not doing it right now? So sometimes people are holding on to things because it makes them feel safe, but it's not doing what we want it to do. So you're kind of holding on to something that's broken instead of thinking how are we going to fix it. So completely agree with that point.
Purva, we're at the end of our panel now. Just a final thought to you. I mean, you've both been in the industry for many, many years and got a lot of experience, and you've identified and been very frank about the problems the NHS is facing at the minute. when you go to bed at night, how optimistic are you that, you know, positive change will be made and that we will sort out the workplace problems that we've been discussing so far today?
I'm an eternal optimist.
Me
So
too.
I've been in the NHS for all these years, and every time I think, oh my God, we're not going to find a solution to this, I've been absolutely amazed how we turn it around, because we are doers. We love the NHS. We're passionate about our patients. I think we'll find a way through this. We just have to be more open. And as I think we heard in the chat box, we've got to do things differently. And I'm sure we will do it. It's just the willingness to change and adapt, I think, which is what we require.
Well, I think we feel safer knowing that people like you and Juliette are around with all that experience to draw on. And again, the time's flown by, as always. 2 guests, but actually lovely to let things breathe a little bit more. Juliette, thank you for joining us for Berlin, and you're on a few days well-deserved break, so enjoy that. And Purva, my instruction to you is go and get some breakfast, because I know you haven't had any yet. It's been a pleasure to talk to you both. Once again, another really engaging panel with so much covered. So massive thanks to Juliette and to Purva. And thank you to everyone who's joined us so far. Make sure you take advantage of what the platform has to offer all the time, scoring points with our gamification tool. Those in first, second and third places voucher or a chance to donate in their name to their chosen charity. And by jumping into the meeting hub, you're building connections with delegates, not just for this event. You'll have the opportunity to connect with delegates who sign up for future events too. So let's meet back here at 2 o'clock after a well-deserved break and a chance to perhaps let some of that information gleaned absorb. I'll see you after lunch. Well done, sir. Back to